Thank you, Suzy. Thank you very much for the introduction, and thank you for. I am not even touching it; it's doing by itself. Okay. Yes, thank you very much, and I will. I'm going to just give you an overview. First, I will talk what we do know about neurobiological deficits in schizophrenia in general, and then I will try to present data and studies that we have so far, which point to neurobiological deficits in patients with schizophrenia who also have a history of violence, as opposed to those who don't have a history of violence. And finally, I'll touch upon whether I think.
What's causing it?
Is it that you've got the mini mic on?
Yeah.
Yes, so shall I stay away from this one?
The main one. I've got that in the back.
This one now, this is probably more battery.
Maybe if I stay away from it.
Yeah, it doesn't like the little mini mic very much.
Or is it? So shall I take it off?
Yeah.
I saw everybody had it.
Oh, they've got
It was
one
off
for the...
then. Did you get the pointer?
It doesn't work, I'm afraid.
Okay.
We're technologically the best here.
Okay, just in terms of when I said I will be talking about neurobiological correlates of violence in schizophrenia, all the findings that I would present to you come from men. We do not yet have any data talking about the neurobiological correlates of violence in women with schizophrenia, and most of the data would have come from patients who are at Broadmoor Hospital. I tend to walk around a lot when I talk, and here I'm restricted to one place. Okay, so generally what is schizophrenia? Well, most of you already know schizophrenia is a chronic condition characterized by a heterogeneous group of symptoms, including positive symptoms such as delusions, negative symptoms. Importantly, most patients with schizophrenia also tend to suffer from cognitive dysfunction in multiple domains, including attention, working memory, episodic memory, verbal learning, and so on. And performance deficits in general tend to be about 1 to 2 degrees standard deviation below healthy controls. Well, why do we care about cognitive function or cognitive dysfunction? Normally it's the symptoms that gets the patient to the symptom of clinical services. But we do care about cognitive dysfunction because in the longer term, cognitive dysfunction is a stronger predictor of social and functional outcome of the illness than symptoms are. Positive symptoms barely predict long-term outcome. Negative symptoms do, but not as much as cognitive dysfunction does. So people may hear voices, but they will still probably be able to hold on to their jobs. But if they have severe cognitive dysfunction, it has severe effect on their job prospects, family relationships, etc. And some of these may or may not be more pronounced in patients who tend to have a history of violence, as we'll see later. Where does it come from in terms of cognitive dysfunction? It's often present prior to the manifestation of clinical symptoms. So you find that people even who are in the prodromal period of psychosis will have cognitive dysfunction to some level. It's already present at the first presentation of symptoms, that is first episode, indicating that it's not something that happens because of the antipsychotic medication, relates to but separate from negative symptoms. So it's not the same as negative symptoms, although sometimes we tend to find a correlation, and that probably is because if you're, for example, assessing verbal fluency as a measure of cognitive function, and then you are assessing poverty of speech, there is some overlap the way we measure negative symptoms and cognitive function. But generally, cognitive dysfunction and negative symptoms are independent of each other. And cognitive dysfunction tends to persist in chronic patients even when there is significant improvement in their symptoms. So it's something that's cured and enduring, and it has implications for their long-term outcome. Some of these deficits are genetically mediated, and they're also present in milder form in unaffected biological relatives of schizophrenia patients. Moving on from neurocognitive deficits to brain dysfunctions or brain deficits in schizophrenia, the slide I have here shows you structural brain alterations here. In this review, mainly in terms of volumetric alterations, enlargement or reduction. And as you can see, the number that you see in the bracket, 80%, that means that 80% of the studies who assessed lateral ventricles in schizophrenia found them to be enlarged. You can see most brain structures are found to be altered in schizophrenia patients on average to some degree. If you look, for example, here, superior temporal gyrus, when you look at the gray matter reduction, all of the studies that has assessed gray matter volume of the superior temporal gyrus until 2001 found a significant reduction on average. So most brain structures are altered to some level on average, but rarely you find a patient who will have a deficit in all of these regions. So there is a large variation within the population. Patients tend to vary in terms of whether they have, apart from superior temporal gyrus, which seem to be present in all studies, but that doesn't mean it's present in all patients. So there is a large variation. And it may relate more recently studies have moved on from the volume region of interest approach to looking at voxels across the whole brain. And again, if you look at the bars there, that's the number of studies. And if you look at about 75% of the studies have found temporal lobe reduction in the temporal lobe in terms of gray matter volume. So there are a large number of studies looking at these alterations, and they do report significant deficits. The question here for us is, are some of these abnormalities more pronounced in patients who tend to be violent, or is that some of the abnormalities are actually absent in the subgroup that tends to be violent? Just like structural brain alterations, a large number of studies have also looked at, sorry, I'm getting ahead of myself. Brain alterations in schizophrenia, in terms of structural alterations, they have been found to relate to cognitive deficits. There are robust data, for example, showing that those who have hippocampal volume reduction, they also tend to be poor in memory. They may relate to symptom profiles. They may relate to medication use. And when I say medication use here, I mean simply relate because of the pharmacological profile of a drug, unrelated to its clinical profile or side effects profile. And they may relate to treatment response, so you may have more or less deficit, or you might find normalization of some deficits following treatment with certain drugs. And importantly, they also relate to outcome. So patients who tend to have better outcome, for example, they are known to have, in several studies, larger putamen size. And some of these abnormalities are also genetically related. They are also present in relatives of patients. More recently, in the last 20 years, a large number of studies have examined functional brain abnormalities in schizophrenia during cognitive, affective, and sensory motor paradigms. So this is when patients are carrying out a task assessing cognition, affect, or other functions, and studies look at what's going on in the brain in terms of brain activity. And again, you find abnormalities in almost all regions: prefrontal cortex, cingulate, thalamus, striatum, hippocampus, amygdala, temporal lobe, parietal lobe, fusiform gyrus, cerebellum. So again, there are multiple circuits that tend to be dysfunctional in schizophrenia. The paradigm that has been most widely used to assess various effects in schizophrenia in terms of brain abnormalities in relation to symptoms, medication, etc., is working memory paradigm. And if I point you here, this is a meta-analysis, so a large number of patients are involved in this meta-analysis, and you can see that the healthy patients show more activity than patients in the lateral prefrontal cortex bilateral. So it's a very robust deficit that is present in schizophrenia. Recent data, at least there are now 3-4 studies showing that the deficit is present on average, but it is more likely to be present in patients who are treated with typical antipsychotics, D2 blockers. Working memory is our ability to hold information online over short periods and then to either use it directly or to manipulate it in some way to reach a goal. Simple example, perhaps not so relevant in when we use mobile phones, but look at the numbers in yellow pages, go to the phone and then use those numbers to dial, and that is what you're using during that period, or that function is your working memory. And the load can be can be more. So when I say 0 back here, there is no working memory load. 1 back, 2 back. So 2 back, you're holding essentially more information in your working memory when I say 2 back than 1 back. So it's cognitive load. And most healthy people, if you get them to task, working memory task, which has got varying working memory load, you will find that as working memory load goes up, activity in the prefrontal cortex goes up. When the patients are treated with atypical antipsychotics, you see that they start showing a pattern. They might show still on average less activity, but the linear increase from 0 to 1 to 2, that seems to be then present in patients. Those who are treated with typical antipsychotics, you see they actually don't, because they're already using whatever they have to achieve even at a lower working memory task. So some of the brain abnormalities do seem to respond positively to treatment, and it seems that atypical antipsychotics are more effective in that respect. More recently, not only that certain brain abnormalities may normalize or improve with atypical antipsychotics, it seems that brain activity also predicts response to psychological therapies. For up to 40% of schizophrenia patients, they do not show significant symptom improvement following atypical antipsychotic treatment, be typical or atypical. They tend to suffer from distressing experiences. Of those who do not show sufficient improvement following atypical antipsychotic treatment, 50% of those will show meaningful improvement following cognitive behavioral therapy for psychosis. But again, 50% do not show significant improvement. So we are left with a sizable proportion of patients who continue to suffer from distressing symptoms despite remaining compliant with their medication and having received cognitive behavioral therapy on top of it. Who are they? And it seems that the patients who do not benefit sufficiently from cognitive behavioral therapy for psychosis, they have much less activity in the dorsolateral prefrontal cortex and anterior cingulate prior to starting therapy. The implication here would be that if there was a way of improving the dorsolateral prefrontal cortex functioning, anterior cingulate functioning, be recreational drugs, whatever, cognitive remediation therapy, if we could try those before giving or adding to cognitive behavioral therapy for psychosis, maybe we will see stronger improvement, because at this moment we don't have much for that group of patients. Another area that seems to be quite important, certainly for cognitive behavioral psychosis context, is hippocampal volume. And we find that the patients who have greater hippocampal gray matter volume, they tend to show better response to cognitive behavioral therapy for psychosis. Again, we know this is an area which is involved in verbal learning and memory, and that is something that would be very important in the context of CBT for psychosis. They need to remember the conversations within session, between sessions, and do homework or whatever that CBT might involve. So this was all about, more generally, biological deficits in schizophrenia. Now I'm moving on to present data looking specifically at neurobiological correlates of violence in schizophrenia. Before I do that, just a general picture. Some symptoms such as delusions have been linked to presence of violence in schizophrenia. I'll leave that to Professor Coy's talk later on. Substance abuse, you heard from Professor David Nutt and Professor Assertion, that has also been talked about in the context of violence in schizophrenia and in mentally disordered populations. Interestingly, violent behavior, there is some treatments, in particular with clozapine and olanzapine, have been linked to significant improvement in violent and aggression in schizophrenia. And the last two studies published very recently come from research conducted at Broadmoor Hospital. So focusing specifically, what do we know about cognitive deficits in people with schizophrenia who tend to be violent? The answer is very little. There are very little data at present available. Most of the studies have been conducted without paying attention to additional problems such as antisocial personality disorder in the population. So they haven't said whether the person just has schizophrenia, whether they have a dual diagnosis, and what else they might have. And the findings have been mixed. What we really need to try to understand this area is to contrast people with schizophrenia with and without a history of violence. There have been some studies looking at affective abnormalities, and recent data seem to more consistently support that those who tend to be violent, they have poor recognition of fearful facial expressions. At least there are two studies which point in the same direction. And there's another study showing impairability to recognize sadness, but primarily in those who also have higher level of psychopathy. So psychopathy seems to play a role when it comes to affect recognition abnormalities in offenders with schizophrenia. What now I'm going to do is to present to you a series of studies from a large project carried out with Broadmoor patients. In this study, we looked at the cognitive profile of patients with and without a history of violence, and we assessed IQ, memory, executive function, attention, and processing speed. What we found that the violent group had lower IQ and slightly lower, but not necessarily significantly so. Overall, both schizophrenia groups were much impaired on all tasks compared to the healthy participants. So that's not surprising. That's what one would expect. But looking at violent schizophrenics versus non-violent schizophrenics, we find that violent schizophrenia group was much more impaired on the Wisconsin-Kurzor test, which measures executive functioning. So that points to exaggerated prefrontal deficit in the violent schizophrenia group. We also looked at the structural brain alterations in the same sample, and this is the slide that I have here just shows you what's known in the literature generally. And again, studies suffer from the problem that they have got mixed sample rather than violent schizophrenia patients and non-violent schizophrenia patients. What we did is that we looked at the brain structures, whole brain volume, cerebellum, temporal lobe, lateral ventricles, caudate nucleus, putamen, thalamus, amygdala, hippocampus. Rather than just being obsessed with amygdala or hippocampus, we looked everywhere to see what actually is impaired and what isn't. We also looked at the four regions: prefrontal, premotor, sensorimotor, and occipital, parietal. But you probably, just to explain to you, it was quite crude at the time the way we did it. It's simply prefrontal, premotor, so it's not the best division. But what we did find that there was whole volume reduction in both schizophrenia group to some level, but violent schizophrenia group showed significant reduction even compared to non-violent schizophrenia group. So that is an additional deficit that we find in the violent schizophrenia group. And also hippocampus was much more reduced in the violent schizophrenia group than it was in the non-violent schizophrenia group compared to control. So you generally have hippocampal volume deficit in schizophrenia, but it seems to be much more pronounced in the violent schizophrenia group. Because in our first study we had used rather crude measures to look at the prefrontal volumes, the data were then further analyzed by the UCLA group in their collaboration, and then we find that if you look at here, schizophrenia, the study had 4 groups. There were 2 schizophrenia and 2 non-schizophrenia groups. There you find the prefrontal reduction as has been shown in many other studies, but we find inferior frontal reduction as well when we look at the violence. So the inferior frontal reduction, which has been shown or is suspected more in the orbitofrontal, we do find that, but that deficit was more strongly present in the antisocial personality disorder group with a similar history of violence. We further looked at whether the orbitofrontal cortex reduction and hippocampal volume related to behavior, and here we looked at dysfunctional impulsivity. Dysfunctional impulsivity and impulsivity are not necessarily the same. Being impulsive in some situations, such as in sport or crossing the road when you see something, is actually helpful. Dysfunctional impulsivity is when it's not beneficial to act fast without thinking. And in Ising's model, venturesomeness actually is impulsivity when it can be helpful. So functional impulsivity, impulsiveness is what we call dysfunctional impulsivity and empathy. And if you see, that's the group of patients with a history of violence. This is non-violent schizophrenia group, and you can see dysfunctional impulsivity is clearly increased in the violent schizophrenia group. In terms of brain, what do we find? We find that dysfunctional impulsivity correlates negatively. So those who have larger orbitofrontal cortex gray matter volume are less impulsive. That finding it stands true both in the control group as well as in the patient group. Interestingly, hippocampus volume seems to contribute, or rather hippocampal reduction, hippocampal deficit seems to contribute to dysfunctional impulsivity more so in schizophrenia groups than it seems to be doing in the control groups, much stronger in the schizophrenia group. Hippocampus is not necessarily talked about when we think of dysfunctional impulsivity, but it certainly seems to contribute much more in the schizophrenia population, more so in the violent schizophrenia population. The same project, we also looked at brain responses during 3 functional MRI paradigms. We use working memory paradigm, motor response inhibition, anticipatory fear. And just to explain the paradigm to some of you who may not be familiar, it's called one back task, and the loads are 1 back or 2 back. When I say subjects are lying in the scanner with a button box, and the box has 4 buttons on it, during the 0 back condition, which is our no working memory load control condition, all they have to do is to press a dot which corresponds to what they see on the screen. So on the screen they will have a figure like that, and the dot will appear somewhere. On the 0 back condition, they will simply press wherever they see the dot. In the 1 back condition, they will have to press the location where the dot appeared on the previous screen. So if the dot appears here, and if it's a working memory load 1 back condition, they will press here. On the next trial, they will press that location, and the dot will move on to some other position. When it's a 2 back condition, then they will have to keep on remembering where the dot was 2 screen back, and keep on encoding and responding and so on. What do we find? This is the 0 back condition where the groups don't actually differ. The study also has an APD group, that's the APD group, but that's the non-violent schizophrenia group, and that's the violent schizophrenia group. So they are doing the task pretty well on the 0 back, so they are motivated to do it. Attention is not a problem. But when it comes to 1 back, I have to keep my fall, then violent schizophrenia group now is significantly impaired. This is a non-violent schizophrenia group, which is showing deficit compared to healthy controls. But it's the violent schizophrenia group that seems to be quite severely impaired. And that fits in again with the prefrontal functioning, dysfunctioning. Looking at what do we find when we look at the brain activity, that's the healthy control group. And you see lateral prefrontal cortex, anterior cingulate, parietal cortex. This is a typical working memory network. When people are engaged in working memory tasks, that's the network normally lights up. That's responsible for the executive components of the task, and that's more to do with the short-term storage of information, which allows us to see exactly where the problem might be. This is a schizophrenia group. You can see they are activating the same network to a less degree. So they do have deficit, but the network seems to be pretty similar. You can't see probably T value. That's the maximum T value is 8 here, there is 15. So although they're activating generally to much less. And that's very consistent with literature generally, schizophrenia versus control. Now looking at the violent schizophrenia group, now you can see the maximum value there is 4. And you can see there is barely any activity on the left prefrontal cortex. So prefrontal deficit seems to be much more robustly present in the violent schizophrenia group. Motor response inhibition, very simple task. Every time they saw a smaller circle, they had to press, they would have to stop. Every time they saw a large circle, they were asked to just press a button. So there are lots of go trials. And suddenly you have a smaller one, and you see then the instruction to them is don't press. What we found, both schizophrenia groups showed impaired performance, generally across all conditions. So they were slower generally. They did respond, but they were slower. And they made more errors than the healthy control group. But interestingly, violent schizophrenia group showed reduced cardiac activity during inhibition conditions, so they were not as effective, and that's more likely to with the timing of the response, because it's the caudate rather than the orbitofrontal cortex here. So again, there seems to be additional deficit present in the violent schizophrenia group. Finally, third, a functional MRI paradigm, we looked at the neural and behavioral responses to threat. What do we do in this paradigm? Well, Dr. Das put a lot of work into this paradigm. It's a very simple paradigm in the sense that you have 30 seconds shock period, 30 seconds, so 30 seconds on, 30 seconds off. During on period, they are told that when you see shock on the screen, you may get electric shocks. During the safe condition, there is no possibility that you will get any shock. And before they went into the scanner, we worked up a procedure. We figured out what was the shock that they found really unpleasant. I mean, the degree of shock, how intense it was. And then they were told that once you are in the scanner, the shocks you will receive will be either of the same intensity or they will be stronger. So this is simply the procedure that I just described to you. And after they came out of the scanner, we asked them how fearful they were during the shock condition and how strongly they believed that they were going to be shocked. In reality, no one got any shock. It was all just fake. What we found is that if you look at, this is the schizophrenia, that's the healthy control group, that's the safe shock. And if you look at the non-violent schizophrenia, they are not that much different from healthy controls in terms of how fearful they were. But if you look at the violent schizophrenia group, that's the group that seems to be reporting being most fearful. And they also is the group that seems to believe that they're going to get shocked, as opposed to other groups. Whereas I'm not talking about the APD group in the interest of time, but they were least fearful and they believed they were not really going to get shocked. They believed the least. That's not surprising. In terms of general brain activity, the paradigm activated anterior cingulate, thalamus, insula, that's a very typical network that people activate when they are expecting, when they are anxious, when they are expecting painful or unpleasant stimuli. This is the interesting part. So, but we also examined activity because we had 30 seconds on-off blocks, and in some brain areas, such as amygdala, for example, brain activity habituates quite quickly. So we looked at analysis in terms of first second seconds of the block and the later 20 seconds of the block. And what we found is the later 20 seconds, when they must have believed it hasn't come so far, it's really not going to get shocked. You find that this violence schizophrenia group is actually showing much more activity in the anterior cingulate, in the striatal thalamic complex that you can see on that slide again. This is the violence schizophrenia group, and that's the healthy control. And that's a non-violent schizophrenia group. They don't seem to differ much in this, but violent schizophrenia group seems to be activating the threat network much more strongly and in a way, slightly aberrant way. More recently, we have become interested in looking at childhood abuse in relation to the structural and functional brain abnormalities we have found so far. In the same sample, we had looked at, we had measured psychosocial deprivation in terms of physical abuse, sexual abuse, neglect, extreme poverty, foster home placement, criminal parenting, severe family conflict, broken home. And if you look at the data here, of this sample, about 79% of the APD group and dissociative disorder had suffered significant psychosocial deprivation, primarily severe sexual and physical abuse. In the violent schizophrenia group, 54% had suffered, and in the non-violent schizophrenia group, there were only about 27%. So you can see that the incidence of childhood abuse is much higher in the violent schizophrenia group, and there is independent literature showing childhood abuse is linked to criminal behavior generally. And in the physical abuse, interestingly, was the most common and most severe type of abuse deprivation in the violent schizophrenia group, as opposed to the APD group, where it seems to be sexual abuse seemed to be more common. One could argue perhaps schizophrenia patients simply didn't report, but there is no reason to believe that the two groups will report differently in terms of physical and sexual abuse. And there is more recent reports confirming similar finding in a much larger sample. We looked at whether childhood abuse was related to some of the brain abnormalities we had noted earlier, and what we found that childhood abuse significantly associated with thalamic volume reduction. On the whole, we hadn't found thalamic volume reduction in the violent schizophrenia group earlier on, but here we find that those who had a history of significant childhood abuse also had significant volume reduction of the thalamus. Obviously, what we can't say, because it's a cross-sectional study, we can't say whether those who have sensory thalamic deficit to start with, once they're abused, whether they are more likely to become violent, or is it that those who have childhood abuse, for some reason, it may be that recurring thoughts, inability to suppress, whether that leads in the long term volume loss of the thalamus. Regardless, they have a deficit and something that we need to think about. We've also looked at anterior cingulate volume recently in relation to violent behavior, and that's the volume that we measure, and looking at that's the violent schizophrenia group, that's the APG group, that's the non-violent schizophrenia, and that's the healthy control group. You can see both antisocial personality disorder group and violent schizophrenia groups have anterior cingulate deficit, and that will fit with the problems in impulsivity and other areas that are commonly reported. Interestingly, once you take childhood abuse into account, the groups are no longer different, suggesting that although it's a deficit that's very often reported in antisocial populations, it seems to be explained almost fully by childhood abuse history. In other words, clinicians who are dealing with this population need to take childhood abuse into account quite meaningfully. So overall, sum up, what do we know so far? Well, executive function deficit seems to be over and above in violent schizophrenia patients to that we generally see in schizophrenia patients. There seems to be more severe whole brain and hippocampal volume reduction. And hippocampal volume reduction seems to contribute to dysfunctional impulsivity. We have reduced frontal response and poor working memory. We have higher threat anticipation and associated brain activity in the violent schizophrenia group. We also have reduced thalamus and reduced anterior cingulate, which then in turn is explained by a childhood abuse history. So clearly the profile of a violent schizophrenia patients in terms of neurobiology seems to be different, or it seems to present with additional deficits than what we see generally in schizophrenia patients, and these may well have implications for their longer-term treatment outcome. For example, we see that in general schizophrenia patients, anterior cingulate and lateral prefrontal cortex activity predicts response to cognitive behavior therapy psychosis in the longer run. Whether similar effects are present in this population, we don't know at this moment. But it's highly likely that neurobiological characteristics do have implications for outcome, both in terms of what as a moderators of treatment response and also modulation of certain therapies to fit more with the clinical picture. There are very little data at the moment looking at or examining neurobiological or using objective predictors to look at treatment outcome. And also very little we know at this moment in terms of how those violent schizophrenia patients who in addition have antisocial personality disorder differ from the general schizophrenia patients and just the pure violent schizophrenia groups. That work is currently in progress at Broadmoor, Susie Young, Dr. Das, Otley. We're also looking at the relationship of, so we are characterizing additional groups that we haven't done before. We are looking at the relationships of neurobiological abnormalities with treatment outcome. And hopefully, we will be able to inform interventions once we have collected all these data. I would thank a very, as you can see, it's a large number of people that have contributed very significantly to this work. To name a few who are present here, Dr. Malagenda Das, Dr. Susie Young, Ms. Ottilie Sedgwick, who is a PhD student leading on some of the bits that I described, Professor Gisli Gazinashan, and various other people. You probably remember other names who were based at Broadmoor in the past. So I thank everyone. And the structural MRI part was supported by the Stanley Research Foundation. Functional was Stanley Foundation. Structural via the Zito Trust work, and childhood abuse work was recently supported by the British Academy. And I thank everyone and thank you for attention.